Hello doctors, can you hear me? Hello? Yeah. Hello doctors, good evening. Good evening doctors. Can you hear me guys? Please, yeah, perfect. So, very good evening to one and all. Let's discuss the MIQ questions that you would have taken. Uh, yes. So, guys, let's begin with the very first question. Now, when it comes to the first question, here it is. It's going to be a question about a 68-year-old man with end-stage renal disease misses several dialysis appointments. Uh, just a minute. Hold on. All right. Just a minute, doctors. Hello, sir. Okay, what should I do? Just a minute. Yeah. Doctors, just a minute, doctors. There is a small technical glitch. We'll connect the screen now. What should I be doing, sir? I'll do that. Shall I stop the streaming and shall I start it again? So, now? Not it? Oh my God. What are you seeing in the screen, sir? Video? All right. Just a minute. Yeah. Okay. All right. Just a minute, sir. I'll do one thing. I'll disconnect and I'll remirror it. Then we'll see, sir. Yeah. Can you see now, sir?
Sir, can you accept my request once?
Yeah.
No, sir.
All right.
1 second, sir. 1 second.
Yes, please.
I'll check. First, stop the streaming, sir.
All right.
Share the screen now.
Just a minute, sir. Just a minute. Now, sir?
1 second, sir. I'll check it. Now okay, sir. Now okay.
Okay. Can you able to see the writing, sir?
Right, sir. Once.
Now?
1 second, sir. Yes, sir. Yeah.
Perfect. All right, sir. We can connect. Yes.
Okay. Done, sir.
Done, sir. Done. Guys, can you hear me? Yeah. Guys, can you hear me, people? Yeah, very good. So, sorry for this technical glitch. I seriously don't know what went wrong, but anyway, thank God it got settled. Now, let's begin with the very first question, people. The first question says, 68-year-old man with end-stage renal disease misses several dialysis appointments. A routine blood test reveals serum potassium level of 7.2 milliequivalents. That's the first clue. 7.2 milliequivalents, and the question says the normal value is also given. It's 3.5 to 5 milliequivalents per liter. This change in extracellular potassium concentration will have which are the following effect on resting membrane potential of his cardiac myocytes, also called as cardiocytes. Alright, so here is the question. B is the right answer. Very good. Resting membrane potential will be less negative. The membrane will attempt to get depolarized. Very good. Perfect answer for this question. Very good, people. So every time there is going to be hyperkalemia. So you guys know this very well. So if there is going to be hyperkalemia in case of excessive potassium in the extracellular fluid, so this is going to make increase in intracellular fluid potassium level as well. So hyperkalemia leads to increase in intracellular potassium level as well, and that in turn leads to depolarization. So B is the very right answer for the question. Perfect. So that's the very right answer, guys. B is the right answer for the question. So as and when there is going to be ECF potassium level increasing, that in turn increases intracellular potassium level, and that leads to depolarization. That's a very right answer. Good. So let's move on to the second question. During a vigorous workout, a 25-year-old weightlifter experiences forceful muscle contraction. Which of the following events occurs at the level of sarcomere during this process? A band shortens as myosin filaments slide past. Calcium binds to myosin head, causing conformational change. ATP binding to head of myosin, causing power stroke. The I band and head zone both shorten. Yeah, good. Very good. That's the right answer, guys. D is the right answer for the question. There is a shortening of I band as well as head zone, both get shortened. Very good. So just a minute, we have a doubt here. Sir, how is excitability affected by pH? Because low pH causes less excitability, sir. Isn't less pH associated with high potassium? All right, doctor. I don't know what, anyway, your name is not getting displayed, but anyway, excitability affected by pH. So when it comes to that question, that's a very good question. People, just give me a second, I'll finish the doubt and then I'll come back to this one question once again. See, when it comes to the change in pH, every time if a patient is experiencing acidosis, this acidosis will lead to hyperkalemia. Acidosis will lead to hyperkalemia on one side. On the other side, when it comes to the direct effect of acidosis, acidosis is going to be inhibiting neuronal excitability. Is going to be directly inhibiting neuronal excitability. So when the question is about pH, you can expect the answer for that question in two different aspects. If the question is very specific about effect of pH over a neuron, the answer is direct and straightforward, that acidosis inhibits neuronal excitability and that makes the neuron not to become excitable. And when are you seeing this one point? You're going to understand this, neuronal excitability and acidosis. This is happening in metabolic acidosis, for example, diabetic ketoacidosis. So whenever patients experiences diabetic ketoacidosis, which is nothing but a metabolic acidosis, there is going to be a drop in neuronal excitability, which is why patient slips into coma, which we call this as diabetic hyperosmolar coma and everything, right? So just be clear, if the question is direct about a neuron and acidosis, you must pick the excitability is going down, the resting membrane potential will become too negative, there is going to be hyperpolarization. On the other side, if the question is not about neuron, the question is randomly about some cell, you can expect that acidosis will be causing hyperkalemia, and in that situation we may expect an increase in excitability. All right, so that's the question and answer for your question, doctor. All right, so I hope you get this point. Change is good, that's your name that is getting displayed anyway. So I hope you understood what you have to pick if the question is about pH. All right, good. All right, other guys, Dr. DP, how many questions done? This is the first question, Dr. DP, don't worry, this is the very first question. And moving on to second question. Of course guys, you all said the right answer. A and M band unchanged, H and IHZ decreases. Anshita, there is a small change you got to be clear about. So when it comes to the changes, you are going to find A band which is going to remain the same. There is not going to be any change in A band. So let's put it this way, A band is going to be remaining the same. A band remains same. And when it comes to I band, as you guys correctly said, I band gets shortens. Alright, I band remains shortened. And when it comes to head zone completely disappears. So this is what I need you to be very clear with. Alright, I band is getting shortening where a head zone is getting disappearing. Alright, this is the right answer. But when it comes to this question, the question says that A band shortens as myosin filament slide past actin, which is clearly wrong. Option B, calcium binds to myosin head causing conformational change. When it comes to calcium combining with myosin head, this is not the case, because calcium, you guys know, will be combining with troponin C. Calcium combines with troponin C. This is not going to combine with myosin head, and hence option B is also wrong. Option C says ATP binding to myosin head causing power stroke. This is also wrong. You know the answer well. If ATP combines with head of myosin, this will be causing relaxation. So every time a new ATP combines with head of myosin, this will be causing relaxation and not contraction, and hence option C is also wrong. So three choices are ruled out, and the best answer is going to be option D, which is I band and head zone both shorten, which is why we are picking this as the right answer. All right, good. Very good, people. Very good answer. Good. And that takes us to the third question. A patient experiences a sharp localized pain sensation immediately after touching a hot stove. This initial rapid pain signal is transmitted to the central nervous system primarily by which type of nerve fiber? And that takes us to the next question, guys. Yeah, answer please. Beautiful answer. Very good, very good. It is going to be A delta fibers. Good. So very good, guys. A delta fibers is going to be the one that carries sharp pain as well as cold modality. Sharp pain and cold modality is sensed by A delta fibers. Whereas when it comes to A alpha fiber innervates extrafusal muscles. It innervates extrafusal muscle fibers. And when it comes to the sensations, it is A alpha fiber that carries touch sensation as well as dynamic proprioception. So touch, dynamic proprioception, extrafusal muscle, these are all carried by A alpha. Coming to C fibers. C fibers carries slow pain. It carries slow pain. It carries warmth modality. Slow pain, warmth modality, and this is also involved in postganglionic autonomic. Yeah, postganglionic autonomic. And when it comes to B fibers, this is very clear. B fibers are going to be carrying preganglionic autonomic. All right. So if you consider all the choices, the best answer is going to be option B. So option A is ruled out, C is ruled out, D is ruled out, and the best answer for the question happens to be option B, guys. This is the right answer for the question. Very good, guys. Beautiful answers. So that's question number 3. And we are going to move on to question number 4 here. That's nice. Yeah, now we have question number 4 here, guys. A biopsy of gastrocnemius muscle from an elite marathon runner would most likely show predominance of which muscle fiber? That's question number 4. Option A, type 1 fibers with high myoglobin content and high mitochondrial density. Option B, type 2B fiber with low myoglobin content and high glycolytic capacity. 2A fibers with high myoglobin content and high glycolytic capacity. Fibers with low capacity for oxidative phosphorylation. That's going to be option D. Out of these 4 choices, the correct answer happens to be very good. Harshimran, this is A, guys, right? Option A is the right answer for the question. It's a gastrocnemius muscle, and this muscle is taken from a marathon runner, which means, so this is an activity which is going to be high endurance activity. So this is going to be a high endurance activity, which means the muscle must be made of a cell, and that cell must be having a very high capacity to work for a long duration of time, and these muscle must be very least resistant to fatigue. So if you look at that kind of muscle which has got very high endurance and least resistant to fatigue, sorry for this small mistake here, it is going to be, it's very resistant to fatigue, we'll put it this way. So this muscle doesn't get tired easily, it can keep working for a long duration of time. Such characteristic feature is seen in type 1 fiber, and in order to support this aerobic glycolysis for a long duration, we do have high myoglobin, and in order to synthesize ATP, there is going to be high mitochondrial density as well. So A is the right answer for the question, guys. So this picture will give you enough clarity. You can clearly see the picture 1. These cells are going to look red in color. You can see lot of red color cells here, isn't it? So there is going to be lots and lots of red color cells. These cells indicate high myoglobin content. When it comes to type 2A, there are equally distributed white fibers as well as red fibers. And when it comes to type 2B, this is purely looking white in color, and that's sprinting activity. I hope this picture also will give you enough clarity what muscle cells will be having, how much of myoglobin, how much of glycogen, everything. Alright, so this is a simple question, guys. I hope you could able to get this point as well. So slow oxidative red fibers, good, perfect. So that's question number 4. Let's move on to question number 5 here. Question number 5, a 50-year-old veteran who underwent a below knee amputation a year ago reports experiencing a cramping sensation in his amputated foot. The most widely accepted neurological basis for this phantom limb sensation is option A. It says ongoing nerve impulses from the cut nerve in the residual limb. Just because if there is a nerve impulses transmitting in the residual limb, will there be a sensation from the amputated foot? Or option B, reorganization of somatosensory cortex, where cortical areas of the hand and face invade the area formerly representing foot. Option C, psychological expectation and memory of the limb. This is purely psychological. Is this be the right answer? Option D, spontaneous firing of spinal cord neurons in the dorsal horn. Spontaneous firing without any input. Will this be the option? So out of 4 choices, guys, cortical plasticity, good, which means option B is the right answer for the question. Reorganization of somatosensory cortex, where cortical areas for the hand and face invade the area formerly representing the foot. Good. Alright, just a minute. Dr. MS, sir, in notes we have written. Dr. MS, I'll finish this question and then I'll come back to the previous question, Dr. MS. So when it comes to question number 5, this is what you are supposed to be knowing when it comes to phantom limb, doctors. Now, this picture will be clearly explaining what is phantom limb and how is this happening. The first picture shows that here it is the sensory cortex, and just in front of sensory cortex it is going to be motor cortex. So the yellow color region represents motor cortex and the orange color region represents sensory cortex. Now you can clearly see there is a sharp demarcation here. So consider this point as a central sulcus. In front of the central sulcus it is going to be motor area. Behind the central sulcus it is going to be sensory area. We'll put it this way. So when arms have been moved, when there is a movement of arms, you can see that because of a motor activity there is going to be some changes, and that is going to get reflected in the sensory activity as well, which means these regions are clearly sensing and controlling arms. Now when I say arm, that includes hands and fingers, guys. For the second picture, you can see that if there is a loss of hand, when there is a cut, when there is an amputation happening, when the forearm is gone, when the hand is gone, there is no forearm, there is hand now, what's going to happen? There is going to be remapping. See, the region which is supposed to sense face, the region which is supposed to sense lips, now the region which is supposed to sense face is getting into the region which was sensing hand and finger. Please remember, the hand region is not encroaching the face region, rather the face region is encroaching hand region. Alright, so this is the way the cortical remapping is happening, plasticity is happening. This is exactly what we call as restructurization or reorganization of synapse, right? What happens is the neurons which is present in the region which is supposed to receive sensations from the amputated part, these neurons is now hungry for action potentials. These neurons are not getting anything from the peripheral part. So what these neurons do, in order to receive action potentials, these neurons starts to secrete neurotrophic factors. So the neurotrophic factors which is secreted by the neurons of the amputated part will go and make the neurons of the normal part to grow a lot, so that neurons of normal part comes into an anastomotic connection with neurons of the amputated part. So the normal region which do have the body part encroaches into the region which has lost its body part. This is exactly what is called as remapping. Doctors, this was an INICET question, this was a NEET question, this was a FMGE question as well. Be very, very clear. It is not the amputated cortex going into the normal cortex, rather it is the normal cortex coming into the amputated cortex. That is exactly what is called as cortical remapping or reorganization. All right, so when you take up the choices, option A speaks about neuroma. Definitely phantom limb sensation is not because of neuroma, so option A is rolled out. Option B is clearly the right answer, which we just discussed. Option C, they say that this is a psychological expectation. Again, phantom limb is a neurological mechanism, not a psychological mechanism. Option C is also rolled out. Option D, spontaneous firing of spinal cord neuron. This will never happen. This is a sensory neuron. Unless otherwise there is a typical trigger, that particular sensory neuron will not get excited. So clearly B is the right answer for the question, guys. Alright. Fine. So I hope you guys are clear about all these choices. Now, when it comes to the previous question, let me just address the doubts some of your batchmates were asking. In notes, we have written type 2 fibers in marathon runner. No, Dr. MS, never, never, never. Type 2B fibers are for sprinting, not for marathon. All right. So just try to be very, very clear here when it comes to the activities. Let me be very clear, guys. Number one, if it is a low tension, in another word, low force, at the same time high endurance as well as long acting exercises. All right, if the exercise is low tension, low force, high endurance, long acting, this is done by, this one type of activity is done by type 1 cells, type 1 fibers, and these type 1 fibers do have very, very high amount of mitochondria because it is a long action, isn't it? So this mitochondrial quantity has to support ATP synthesis. In order to support ATP synthesis, it requires oxygen. In order to hold oxygen, these kinds of fibers have got a protein in order to trap and hold oxygen, and that protein is going to be myoglobin. Just because the protein myoglobin is abundant in type 1 fibers, these fibers are going to look red in color. So these cells are small cells. These cells are slow acting cells, and hence the name of this cell is going to be type 1. Just be very clear here, the name of the cell is going to be type 1 slow red fibers, and these fibers are involved in high endurance activity, long acting activity, and the best example for this activity is going to be marathon running. On the other side, if you take up a sprinting activity, which means this involves a high tension, which means there is going to be high force required, more load has to be lifted, high tension, high force. All right, but this is a very, very short duration of activity, very, very short duration of activity. If this happens to be a very short duration of activity and that requires high force, high tension that needs to be generated, this requires type 2B fibers. Type 2B fibers. Type 2 fibers have got very, very less amount of myoglobin. All right, the amount of myoglobin is very, very, very less. At the same time, the cytoplasm has got so much of glycogen. Because of glycogen, they go for anaerobic glycolysis, which is why they could able to synthesize ATP quicker. Since there is no myoglobin and more amount of glycogen, these cells are going to be called as white fibers. Number one. Naturally, these cells are very, very big cells. Number two. At the same time, since the ATP production is quick, they could able to act very fast. So these cells are fast acting, also called as fast twitch cells. Fast acting or fast twitch cells, which is why these cells are called as type 2 fast white fibers. So I hope Dr. MS, your doubt is understood. All right, so Dr. MS and Dr. Dra, just be clear, guys. What is type 1? What is type 2B? All right, so when type 1 is coming in, when type 2B is coming in. All right, guys, are you clear with these two muscle fibers? Dr. MS, Dr. Dra here. Pratiksha, amputated foot. Why hands and face taking the representation of foot? They are far apart. That's a very good question, Pratiksha. Pratiksha, when it comes to amputation, this is not necessarily the neighboring region. Any distant region itself can grow. The only difference is the neurotrophic factors secreted by the neurons of amputated part has to act. So in order for those neurotrophic factors to act, the neurons must have enough receptors for the neurotrophic factor. When it comes to the receptors for neurotrophic factors, this differs between you and me and every human individuals, which means when 3 individuals loses their upper limb or loses their forearm, one individual develops this phantom sensation from the face, Another individual develops the phantom sensation from shoulder. Another individual develops phantom sensation from the lower limb. Another individual develops phantom sensation from the neck. So this depends on the neurons which do have abundant receptor for the neurotrophic factors. That's the reason, Pratiksha. That's a very good doubt. Very good. Dr. MS Kamal sir told fast fatigue resistant is type 2A in LRR. Fast fatigue resistant. No, Dr. MS. Type 2A is fast fatigue resistant. Type 2B, please remember, type 2B is fatigue sensitive, which are easily fatigable. Alright. Dr. MS, postural muscle. Which type of muscle fiber for postural? Type 1A. 1A for posture. Raushan Kumar, 100 meter sprint. Type 2B. Type 2B. Preeti, type 2A for which type of action? Very good. So if you consider type 2A, type 2A is used for high force, also called as high tension. Number one, the force is also going to be higher. At the same time, it also involves increased endurance, more amount of time, long action, increased endurance, also called as long action. So type 2A is a balance of both type 1 as well as type 2B. It's a balance, which is why type 2A cells, alright, I'll write it here. Yeah, I'll put it this way. So when it comes to type 2A cells, type 2A cells are going to be called as fast acting cells. They are both oxidative. They have too much of mitochondria. At the same time, they are both glycolytic as well. So type 2A are fast oxidative as well as glycolytic, which is used for high force, high tension as well as increased endurance activity. Alright, this is how it must be given. It must be considered. Dr. MS, Preeti, Raushan, Pratiksha, I hope all of your doubts are addressed. Cortical plasticity, Karthikeya Garg, SK, kindly repeat previous question. I hope SK, your doubt is also addressed, Raja. Guys, are you very clear with question number 4 and question number 5? Any doubts there, people? 3, 4, 5? Are you clear? Everyone, Raushan, MS, please let me know whether you have understood or you are still getting this confused. Yeah, Preeti, it's clear. Raushan and MS. Type 1 for marathon, type 2B for run. Perfect, Pratiksha. Perfect answer. Raushan, very good, Raja. Good, your doubt is done. MS, I'm still... okay, MS have replied. Thank you. Very good, guys. Perfect. So let's move on to the next question. A patient is diagnosed with Klüver-Bucy syndrome. Alright, a patient is diagnosed with Klüver-Bucy syndrome after recovering from herpes simplex. Of course, there is a damage. Alright, after recovering from herpes simplex. Which of the following symptom is most characteristic of this condition? And that is caused by bilateral lesions to amygdala. Alright, Pratiksha C, Teki Takam C, Rizwan C, MS, okay. MS, give me an answer, MS. Alright, people. Okay, C is the right answer for the question. Very good. C is the right answer for the question. Got this wrong, marked. Anshita? Okay, it's alright, pa. Okay, we first understand what is Klüver-Bucy syndrome, and then we look at the choices as well, so that you'll be clear with the choices and what should be the question for the given choices. All right. Yeah, Juneja. Harshimran, amygdala is for emotional memory as well. You are very right. But I'll explain, guys. I'll explain. First thing first, when it comes to amygdala is the region for fear. Amygdala is the region for fear. Most important, it is the region for fear. Number 2, when it comes to Klüver-Bucy syndrome, this is not just a lesion of amygdala alone. So this is going to be a primary damage to amygdala, and to very little extent there is also some amount of damage involved to other limbic structures. So the first and foremost reason why we have to pick hyperphagia and placidity is, since it is the region for fear, in the damage of amygdala, the subject will experience no fear. Point number 1, the subject will experience no fear. Point number 2, there is going to be limbic structure damage. As a consequence, there are going to be some other changes as well. All right, now let us understand what is Klüver-Bucy syndrome with these pictures so that you guys will be aware. I'm sure you guys are very aware and clear with these choices. Number one, let's first focus on the location of amygdala here. So amygdala is located in temporal lobe, medial temporal lobe. All right, so every time there is going to be a damage to amygdala, this will lead to Klüver-Bucy syndrome, number one. And the first and foremost condition associated with Klüver-Bucy syndrome is something called a hyperorality. The subject will have an intense desire to taste everything. See, you must have seen this picture, right? Pirates of the Caribbean, where Johnny Depp used to lick the crab. All right, so that's the first and foremost condition, something called as hyperorality. The subject will have a tendency to lick everything. They will have a tendency to identify everything by tasting it, by licking it. All right, so that's going to be the first condition here. And this picture gives you the data. The first condition is going to be something called as hyperorality. All right, and number two, the subject will have an intense tendency to taste anything and eat anything, and this condition, doctors, is going to be called as hyperphagia. The subject will keep on eating. The subject will not have a sense of satiety. The subject will keep on eating, and this is going to be hyperphagia. They'll be keep on eating. All right, and on the other front, if you look at this picture, this subject cannot be intimidated by any means. All right, so whatever the threat it is, there cannot be any sort of intimidation. And the reason why there is no sort of intimidation is, since amygdala is damaged, there is going to be no amount of fear that can be evoked, and this is exactly what is called as placidity. This is what is called as placidity, and placidity refers to no fear, and there is also going to be no anger. The subject will have no fear, the subject will have no anger as well. And these two kinds of conditions, all right, is what is going to be called as placidity. And placidity can also be explained as emotional nullness. So there will be no emotion that can be evoked out of the subject. That's going to be placidity. And Sri Vishnu was exactly answering the question. There is also going to be hypersexuality. All right, so all these choices, all these conditions, hyperorality, hyperphagia, placidity, these are all the features of Klüver-Bucy syndrome, and it's very clear. Option C says that there is going to be hyperphagia and placidity, and hence that's the right answer. Now, when it comes to other choices, when do we get anterograde amnesia? People, be very clear. Anterograde amnesia is associated with damage to hippocampus. It is associated with damage to hippocampus. Hippocampus damage is the one that causes anterograde amnesia, that's for sure. Just be very clear. This is because of hippocampal damage. Number two, aphasia. I hope you could able to pick why aphasia happens. There must either be damage to Wernicke's area or Broca's area. That leads to respectively, Wernicke's aphasia and Broca's aphasia. So that's aphasia, and that cannot be happening with amygdala damage. And when it comes to hemispatial neglect, it's a very important point. Be very clear. When it comes to hemispatial neglect, this is seen with right parietal lobe damage. Right parietal lobe damage is associated with hemispatial neglect. So option A, B and D are ruled out, and C is the right answer for the question. SK, I hope you now know what is hyperorality. Rizwan, Jack Sparrow, yeah, MCA infarct, very good. Right answer, that's going to be MCA infarct, good. So I hope you guys are clear with these questions. Of course, thanks to Jack Sparrow, he has explained us very clearly about what is Klüver-Bucy syndrome, good. And that takes us to question number 7. Very good, Aces. That's right parietal lobe. Good. That takes us to question number 7. When a photon of light strikes a photoreceptor cell in the retina, it initiates a cascade that leads to a change in cell membrane potential. Which of the following correctly describes this process? Option A says, light causes depolarization of rod cell by opening cyclic GMP gated sodium channel. This can never happen, because every time the light is absent, rods and cones will be in a depolarized state. When light is present, that will lead to hyperpolarization. It's a very classical, simple question. So every time photon strikes the retina, rods and cones will go for hyperpolarization, and this hyperpolarization is because of closure of cyclic GMP gated sodium channel. It's a straightforward simple question, nothing much to discuss or getting confused here. So option C is the right answer for the question. Very good. I hope everyone got this question right. So in the presence of darkness, there is going to be open state, and that leads to depolarization. So D for D, guys, please remember, darkness causes depolarization. D for D. All right. And every time there is going to be light, in the presence of light, there is going to be closure of cyclic GMP gated sodium channel, and this leads to hyperpolarization. All right, good. So that's the right answer for the question, and that takes us to question number 8. A 45-year-old man presents with recurrent peptic ulcers that are resistant to standard therapy. So the first choice is going to be recurrent peptic ulcer, and there is also going to be chronic diarrhea as well. Chronic diarrhea. Upper endoscopy reveals multiple ulcers in the duodenum and jejunum, and when fasting serum gastrin level is looked for, this is markedly elevated, and the patient's symptoms are most likely caused by overproduction of gastrin. So the question is generous enough to give us every single clue. Now the point is, from where gastrin is abundantly produced? People, if you watch close, what could be the right answer for the question, guys? G cells in the antrum, parietal cells in the gastric fundus, a pancreatic neuroendocrine tumor, D cells in the gastric antrum. All right. Why not A? Wow, that's a very good question. Harshimran, good. Let's just understand. When it comes to gastrin producing cells, you have possibilities of gastrin coming from number 1, delta cells of islets of Langerhans, number 2, antral G cells, number 3, duodenal G cells. So we have G cells that produces gastrin located in antrum as well as duodenum. That rules out jejunum. All right. And there is also going to be delta cells of islets that keeps producing gastrin. So if this is the scenario, number 1, G cells in the gastric antrum, that's a possibility, but this is going to be rare than pancreatic cells that causes gastrinoma. Parietal cells in the gastric fundus. Parietal cells in the gastric fundus do not produce gastrin. Alright, I repeat, when it comes to parietal cells, they do not produce gastrin. Rather, parietal cells in the gastric fundus will be producing hydrochloric acid as well as intrinsic factor of Cassel. So option B cannot be the right answer. Option C, pancreatic neuroendocrine tumor. This is more in favor because when it comes to Zolling-Ellison syndrome, pancreatic origin of Zolling-Ellison syndrome is going to be more common than the Zolling-Ellison syndrome arising from gastric cells in the antrum. So between commonality and rarity, option C gets to be the best answer. So this is all about most common, that is all right. So even though gastrin producing G cells are located in the antrum, pancreatic possibilities is more common. D cells in the gastric antrum, no way, because D cells are located in the pancreas and not antrum. When it comes to antrum, this is going to be G cells. So antrum has got G cells, whereas D cells are located in the pancreas, and hence option D also happens to be the wrong answer. A, we are ruling it out because it is not very common, and hence C is the best answer for the question. Alright, I hope this gives you enough clarity. Okay, Anshita, not from stomach G cells because these are resistant to treatment. Not precisely, Anshita. Even we go for vagotomy or anything, we cannot able to suppress gastrin production, because if it happens to be gastrin producing adenoma, it doesn't settle with conventional treatments. All right, so just be clear. Harshimran marked a no problem at all. It, you guys are learning, that is all. It's just a learning curve, so don't lose your heart. It's just one new data you are now knowing. Few moments later you were not having this knowledge, now you are having this knowledge. Feel happy, stay positive and be optimistic, guys. It's a long journey. We have to keep our moral high, we have to keep our enthusiasm on the peak. We cannot let ourselves down at any circumstances. All right, so just stay sharp and stay optimistic. All right, so yeah, Anshita, I mean the case mentions resistance. Yeah, even though the treatment is given, most of the Zolling-Ellison syndrome patients are resistant to all these kinds of treatments. All right, good. Thank you, Tulsi. Thank you. And change is good. Somatostatin from diesel. Will it not decrease gastrin? No, change is good. Doctor, I'm sorry, I'm calling you change is good. Since your name is displayed that way. If it is a tumor, it cannot be suppressed by somatostatin. If it is a normal cell, it can be suppressed by somatostatin. But if it is a tumor and adenoma, it cannot be suppressed by somatostatin at all. All right, good. Thank you, Roshan. Thank you, Divya. Good. Now moving on to question number 9. A traveler returning from a region with poor sanitation develops voluminous rice water stool and becomes severely dehydrated. The toxin produced by Vibrio cholerae causes the secretory diarrhea by which of the following mechanism? Yeah, guys, give it a shot. It irreversibly activates GS protein, leading to sustained increase in intracellular cyclic AMP. Very good, very good. That's the right choice. Option D says it blocks cystic fibrosis transmembrane conductance regulator. This is terribly wrong. And option B, it forms pore. Wrong. It doesn't form pore. It inhibits sodium potassium ATP. Wrong. So the best answer is option C. Now the same question has got many entrance point as well. Let us take up everything first here. Now when it comes to the cells of small intestine, point number 1, please remember, cholera toxin is going to be affecting small intestine and not large intestine, which means this does not affect colon. This is going to affect jejunum. That is going to be entrance point number 1. All right. Now consider this as a blood vessel which is located immediately beneath the enterocyte, which means we have basal membrane here and we have apical membrane here. So on one side we have basal, on other side we have apical membrane. And for God's sake, please remember, apical membrane can also be called as luminal membrane, isn't it? Now the cholera toxin is not going to influence the cell from the basal membrane, from the blood vessel. No, not like that. From the lumen only, cholera toxin is going to influence the enterocyte. So that is going to be your second entrance question. This is not going to be affecting the cell from the basal side. Rather, this is going to be affecting the cell from the luminal side, also called as apical side. That is second entrance question. Question number 3. To what receptor they are going to bind? So this is question number 3. Cholera toxin is going to bind to GM1 ganglioside receptor. That's going to be entrance point number 3, GM1 ganglioside receptor. And entrance point number 4. If the toxin binds with GM1 ganglioside, it gets internalized, and once it gets internalized, it goes and activates a G protein coupled receptor that in turn goes and activates an enzyme, and this enzyme, doctors, is what is going to be called as adenylyl cyclase, and that's going to be entrance point number 4. Adenylyl cyclase is going to get activated. It is going to get activated. Please remember, that's point number 4. And point number 5, it's going to be increase in second messenger called as cyclic AMP. And point number 6, this is going to increase chloride secretion through CFTR channels. Please remember, chloride secretion is going to become accentuated, not getting blocked. Point number 6. And finally, usually the water transport across paracellular spaces. Water from the blood vessel will be taken across the paracellular space into the lumen. Usually this is prevented by tight junctions, but cholera toxin is also going to break tight junctions, guys. Every single one point you are seeing in this picture was a past year entrance question. NEET, INICET as well as FMGE, it is a past year entrance question. You got to be very clear. So there is going to be a breakdown of tight junction, and when it comes to tight junction, the most important protein that is getting affected here is going to be occludins. More than occludins, more than claudins, it is going to be occludins, guys. So if your question paper is giving you both the choices, occludin as well as claudin, you got to pick occludin as the best answer for the question. All right. So please remember, tight junction is getting affected. Every single point is essential when it comes to mechanism of action of cholera toxin, guys. All right. I hope this gives you the enough clarity about the way cholera toxin exerts its action. Now let's take up the next question, question number 10. On a Vigor's diagram representing cardiac cycle on the left ventricle, the mitral valve opens at point where? It's plain and simple. You are studying opening of AV valves. Alright, you are studying opening of AV valve, and the question is very clear. It is about mitral valve. So when does mitral valve opens? Left ventricular pressure exceeds aortic pressure. No way. This cannot happen. If left ventricular pressure exceeds aortic pressure, this will lead to opening of opening of aortic valve and not mitral valve, which is why option A is ruled out. Option A is wrong. Alright, very good people, you guys are answering very well. I'm so happy. Option B is the right answer. When atrial pressure is exceeding ventricular pressure, it pushes the valve open, so that's a very right answer. T wave of ECG, this says that ventricles are going for repolarization. Electrical activity cannot speak for mechanical activity, so option C is also ruled out. Option D, first heart sound is heard. No way. When first heart sound is heard, this belongs to isovolumetric contraction, beginning of isovolumetric contraction, which means this speaks about a phase of systole and not diastole. Alright, when mitral valve is opening, this says that blood is getting into the ventricle, which means it's a diastole. So this rules out option D as well. So all the choices are ruled out and the best answer available is going to be option B, my friends. Alright, B is the right answer. Very good guys, super, beautiful, beautiful. And I've given you the Vickers diagram for your reference, so you can use this diagram when I will be sharing the soft copy to people, and you will be getting the soft copy in the app as well, so don't worry people. So coming to question number 11, and we have 10 more questions. We can finish this quickly. A healthy volunteer stands up quickly from a supine position. Which of the following represents immediate physiological response mediated by baroreflex? Baroreflex, guys. A healthy volunteer stands up quickly from supine position. Which of the following represents immediate physiological response mediated by baroreflex? Answer is going to be B. Now people, I just want you to be very, very clear when it comes to baroreceptors. Right? I hope you guys are very clear when it comes to baroreceptors, guys. These baroreceptors are basically stretch receptors. Baroreceptors are basically stretch receptors. Time and again we are discussing this one point. When it comes to stretch receptors, these baroreceptors are getting activated by increase in pulse pressure, number one. The second mechanism that activates baroreceptors are going to be increase in mean arterial pressure, number two. And we have discussed this so many number of times in the class. If the question is about activation of baroreceptor, you must first pick pulse pressure as the right answer, the best answer. Followed by pulse pressure, you can speak about mean arterial pressure. So every time when the pressure rises, baroreceptor gets activated. But the question says that a volunteer is standing up. When someone stands up, what is going to happen? Blood is going to get pulled into the lower limb. As a consequence, venous return decreases, cardiac output decreases, pressure decreases. When the pressure decreases, baroreceptor firing is also going to get decreased, guys. And hence B is the very right answer for the question. Alright. Beautiful. Decreased BP. Dr. Riluzole. No. Okay. Dr. Riluzole, please remember, when BP is decreased, baroreceptor gets inactivated. Riluzole, when BP gets decreased, baroreceptor gets inactivated. Please make sure that you are very clear there. So every time there is going to be drop in blood pressure, this leads to baroreceptor inactivation. Baroreceptor inactivation. All right, good. We have this topic discussed deep in our B2B app Riluzole. All right, please do check it out. Back to basics. In that section in CVS, we have clearly explained the baroreceptor mechanism and all these things. Increased RV function, SK, beautiful. If baroreceptor gets inactivated, this is going to be leading to increase in rostral ventrolateral medulla activity, which is nothing but increase in sympathetics. Very good, SK, very good. So that's baroreflex, guys. Good. And that takes us to the next question. Question number 12. A physical examination of patient with right-sided heart failure reveals a prominent pulsatile jugular vein. The pressure waveform analysis shows a large pathological V wave. Clear word, large pathological V wave. that obliterates the X descent. This finding is most characteristic of in what situation we are going to find a very big V wave, guys. Very good, beautiful answers. It's a straightforward question and the answer is going to be tricuspid regurgitation. Good. So here you are seeing that there is a very big prominent V wave here, and this is very classic of tricuspid regurgitation. Very good, beautiful answer. And when it comes to the other choices, atrial fibrillation is manifested by absent A waves. It's going to be manifested by absent A wave in JVP. Tricuspid stenosis is manifested by prominent A wave in JVP. Prominent A wave in JVP. Cardiac tamponade is manifested by absent Y descent. So all the choices are explained. So atrial fibrillation absent A wave, tricuspid stenosis prominent A wave, and cardiac tamponade it's going to be absent Y descent. Okay, you guys are answering well. Okay, beautiful. Blunted Y. Okay, perfect, beautiful, fantastic. Let's move on to the next question. Very good, you're doing extremely well. Happy. A patient with septic shock develops a fever of 39.5 degrees Celsius and a metabolic acidosis with a blood pH of 7.20. These changes will affect oxygen transport by causing which of the following shift in O2 hemoglobin dissociation curve? Guys, you are seeing two conditions here. Number one, there is a temperature, increased temperature. Number two, there is an acidic pH of 7.20. Now tell me, increased temperature, acidic pH is going to, who's asking that question? SK, Canon A. I'll come to that point, SK. Just give me 1 second. I'll finish this and I'll come to the point. All right. Okay. Guys, for this question, it's increased temperature and acidic pH. It's clearly going to be rightward shift of oxyhemoglobin dissociation curve. And I'm sure you are aware that every time if there is a acidosis and if that curve is getting shifted to the right, acidosis shifting the curve to the right, and this effect is going to be called as Bohr's effect. It's going to be called as Bohr's effect. All right, good. So yeah, and you have every picture given in this, every condition given in this picture, doctors. All right, very good. And just give me 1 second. Who was asking that question? Okay, sorry if I missed it. Doctor, when it comes to Canon A wave is seen in complete heart block, also called as idioventricular rhythm, also called as total AV dissociation. All right, where atrium and ventricle become separate chamber, which means atrium and ventricle will contract at the same time. So as a consequence, the pressure is going to be tremendously elevated, and this makes the blood to get back into the jugular, and jugular become enormously distended during atrial contraction, and that is called as Canon A wave. And Canon A wave is seen with third degree heart block. All right, Dr. Elizol is right. It is called as junctional block, complete heart block. MS was saying, SK, I hope your own colleagues are helping you to get this point clear. Perfect. Kirti, junctional rhythm. Hemant, AV dissociation. Very good, people, very good. MS, right shift, increased pH, carbon dioxide, anemia, altitude. Very good, beautiful answer, exactly. Awesome, people, awesome. So happy, you guys are answering very well, very well. And MS, PSVT is not the right answer. Paroxysmal supraventricular tachycardia is not the right answer. MS, it is complete heart block, third degree heart block. That's all. It is not PSVT. MS, please change that answer here. Bavadirano, yeah, Bavadirani, very good, ma. You're right. It's very clear explanation. Very good. So that's question 13, and let's move on to question 14. The Hering-Breuer inflation reflex is a protective mechanism that is activated during breathing. What is the primary stimulus and the resulting response of the reflex? What stimulates Hering-Breuer inflation reflex, guys? It's obvious that Hering-Breuer reflex is mediated by mechanoreceptors. Mechanoreceptors in the lungs. So these mechanoreceptors in the lungs will be involved in sensing overstretching of the lung. It stretches over distension. If lung gets over distended, that is going to activate these mechanoreceptors. And this senses over distension. So it's a very, very clear, straightforward, simple question. Option A says low arterial PO2. Option A is wrong, because if it is low arterial PO2, this is going to be stimulating chemoreceptors and not mechanoreceptors. And this will create a chemoreflex and not Hering-Breuer reflex. Similarly, high arterial PCO2 is also going to stimulate chemoreceptors, and they will bring about chemoreflex and not Hering-Breuer reflex. Option C is the right answer because it speaks about lung inflation. Option D, irritation in the airway. No, this is not about irritation in the airway. This is about excessive stretch, alright, due to hyperinflation. Harshimran, explain A option in this. Yeah, A option is chemoreflex, Harshimran. Don't worry, I will be doing it. Don't worry. I hope you understand what A is all about, isn't it? So, good. Anshita, central chemo, PO2, peripheral chemo, hypoxia. Yes, Anshita. Very good answer. Very good. Good. Perfect. Harshimran, are you clear with this question and options, pa? Yeah, perfect. Good. And that takes us to question 15. A mountaineer acclimatizing to an altitude of 14,000 feet will experience several physiological changes. Which of the following is a key early adaptation that directly enhances gas exchange? Doctors, you have to think about the mechanism which is happening in the earliest point. This is supposed to adapt the subject to the high altitude. At the same time, this enhances gas exchange. Alright, that's the question. Option A, increased production of red blood cells, polycythemia. This is very, very right choice, but it cannot be the right answer because this is a late factor. This is not an early function. This happens late. A respiratory acidosis due to carbon dioxide retention. No, because of hyperventilation, there is going to be carbon dioxide washout. There cannot be carbon dioxide retention. So A is a late response. B cannot be the right answer. C, hyperventilation due to respiratory alkalosis. Very, very right choice. Option D, a leftward shift in O2 curve. No way. In high altitude, you know that there is going to be hypoxia. Because of hypoxia, there is going to be right shift of oxyhemoglobin dissociation curve and not left shift. So this cannot be the right answer as well. And the best answer for the question is going to be option C, hyperventilation leading to respiratory alkalosis. Alright. And that's going to be question number 15. I hope you guys are clear there. Techie, that's good. That's a late response. Very good. Very good. And moving on to question 16. A patient is treated with ACE inhibitors for hypertension. Alright. By blocking the production of angiotensin II, this drug causes vasodilatation of efferent arteriole. Alright. That's the statement. Vasodilatation of efferent arteriole. And the question is very clear. How will the tubuloglomerular feedback mechanism respond to a primary increase in GFR resulting from vasodilatation? So you are supposed to recognize what is tubuloglomerular feedback response if there is an increase in glomerular filtration rate. Very, very clear. So it's an increase in glomerular filtration rate, and very good. Macular densa will sense increased sodium chloride delivery, and this leads to signal for afferent arteriolar vasoconstriction. So option A says macular densa will sense decreased sodium chloride. This is wrong. There is an increase in GFR, which means there must be an increase in sodium chloride. So option A is ruled out. Option C, juxtaglomerular cells will release more renin in response to increase in GFR. This will not happen. When does renin will be released? Every time there is going to be decrease in pressure. As a consequence of decrease in pressure, there must be decrease in filtration of sodium, decrease in filtration of chloride. Only when there is a drop in pressure and decrease in filtration of sodium chloride, this will lead to increased renin release. But the question says there is increased sodium and chloride filtration. So option C cannot be the right answer. Option D, the mechanism will be inhibited leading to further increase in GFR. No way. Tubuloglomerular feedback is supposed to keep the GFR within the autoregulatory range. Alright. Which means GFR has to be kept normal. The mechanism will be super active. This cannot get inhibited. So D is also ruled out, and the best answer for the question is going to be option B, guys. Alright, very good. I hope you guys are all clear in this. So there is no doubt you guys are explaining. Beautiful answer. Very good. So that's going to be question 16, and we move on to question 17. Arterial blood gas analysis from a patient with severe anxiety attack shows the following pH. It is 7.52. Carbon dioxide level is 28 millimeters of mercury. Bicarbonate is 24 milliequivalents. Based on this value, what is the primary acid-base disturbance? Yeah, people. So, hurry up. What could be the best answer for the question? Okay, acute respiratory alkalosis. Beautiful. Anshita got this wrong. Ignored by. Oh my God, Anshita, you have to see bicarbonate. All right, it's okay. It's a lesson that you're learning. That is all. It's a careless mistake. I can be very sure that what you've done is a careless mistake. So it just requires an element of attention and focus. That's all. Now just practice yourself on focusing every single detail the question is giving. All right. So super guys, it's a very right choices you have picked. It's going to be acute respiratory alkalosis. So as the formula goes, you first have to look at pH. In this question, the pH is increased, which means it is clearly alkalosis. And what is the second step we got to look for? We have to look for the inverse relationship between partial pressure of carbon dioxide as well as pH. Now this question says yes, there is an inverse relationship, isn't it? If the answer is no, if there is no inverse relationship, it can be considered as a metabolic disorder. But if there is an inverse relationship, it must be considered as a respiratory disorder. So clearly the pH is increased, PCO2 was decreased. pH is increased and PCO2 was decreased. You are seeing an inverse relationship. Clearly this is a respiratory condition. So option A, metabolic acidosis, wrong. Option B, respiratory acidosis, wrong again. Option C, metabolic, wrong. And clearly the answer is going to be acute respiratory alkalosis. Alright, acute respiratory alkalosis. Now, Anshul, beautiful question. Why are we saying this as acute? Because this problem is not compensated yet. If this happens to be a chronic problem, it would have been easily compensated. Now bicarbonate levels are very, very normal. Since bicarbonate levels are very normal, this means that there is no compensation. So this is going to be uncompensated respiratory alkalosis. Since there is no time for compensation to happen, we call this as acute respiratory alkalosis, guys. So clearly it is a case of uncompensated situation, and hence it is going to be acute respiratory alkalosis. All right, yeah, Divya, super answer. This is not compensated. Very good. Harshimran, it's simple. Harshimran, you first have to look at the pH. pH says clearly that it is an alkalotic disorder. All right, now the second step is you got to compare pH and PCO2. Always the relationship between pH and PCO2 will be inverse, which means if pH is increased, PCO2 will be decreased. If pH is decreased, PCO2 will be increased. If you find this relationship, inverse relationship, definitely it is a case of respiratory disorder. But if you don't see the inverse relationship, which means, pH is increased, but PCO2 is normal, or PCO2 is also increased, which means you are not seeing an inverse relationship. If you don't see an inverse relationship, this is classically a case of metabolic disorder. So that way you can able to pin down whether the question is talking about respiratory pathophysiology or metabolic pathophysiology. Harshimran, are you clear with this, pa? Okay, previous question. Oh my God, you could have said that a moment before, no? Anyway, fine. So here, when it comes to the previous question, it is all about tubuloglomerular feedback. Harshimran, it's a simple question, pa. When it comes to renin, renin is secreted only when there is a drop in pressure. All right. Increased filtration of sodium and chloride indicates that the pressure is high and the pressure is not reduced. All right. So this is the reason you are not answering option C as the right answer, because option C says juxtaglomerular cell will release more renin. This cannot happen. When do you get more renin? Right? When are you going to get more renin? Every time there is going to be decreased pressure, which means there is a drop in sodium, drop in chloride filtration, only then you are going to have more renin. All right. So just be clear, more renin is produced when the pressure is less, which means sodium and chloride filtration is less. So C is wrong. Option A says the macrodensa will sense decreased sodium and chloride delivery. How is this possible? The question itself is saying that there is increased GFR. How can you get a decreased sodium chloride delivery? No way. Every time if GFR is increased, obviously this increased GFR is supposed to be bringing more filtration of sodium, more filtration of chloride. Right, more filtration of sodium and chloride. So option A is wrong, C is wrong. And in order to get the GFR back to normal, you have activation of tubuloglomerular feedback, and option D says the mechanism will be inhibited. This is again brutally wrong. So the best answer for the question is going to be option B. Alright, Harshimran, I hope you get this point. Neha, sir, in question, vasodilatation of afferent and efferent affects GFR. Oh, that's a very good doubt, Neha. See, the point is, the statement here says that the patient is on angiotensin converting enzyme inhibitor and this drug causes vasodilatation of efferent arteriole. That's the statement. But when it comes to angiotensin converting enzyme inhibitor, it will dilate both afferent as well as efferent arteriole for one reason. Just be clear in this. When it comes to angiotensin 2, angiotensin 2 is a vasoconstrictor, and this vasoconstricting effect is going to be not only on efferent arteriole. Just be very, very clear here. Angiotensin 2 is going to be constricting. It's going to be constricting efferent arteriole first. It is going to be constricting efferent arteriole first, followed by afferent arteriole. So please don't think that angiotensin 2 is going to be constricting only efferent arteriole. It primarily acts on efferent arteriole and then it is going to be acting on afferent arteriole. So if a patient is put up on angiotensin converting enzyme inhibitor, this is going to relax efferent arteriole first, afferent arteriole next. As a consequence, there is going to be vasodilatation. There is going to be vasodilatation of efferent arteriole first, followed by afferent arteriole next. As a consequence, there is going to be increase in renal plasma flow, and there is also going to be a parallel increase in glomerular filtration rate. Alright, so that's the way it has to be considered. Alright, so in question 16, efferent arteriole dilated to GFR decrease. MS, if you have a corresponding parallel relaxation of both the arteriole, efferent arteriolar dilatation, afferent arteriolar dilatation as well. Just because there is going to be a dilatation of afferent arteriole as well, there is going to be increased renal plasma flow and increased GFR. Just be clear. You guys are very right. If there is going to be a isolated dilatation of efferent arteriole, GFR can be decreased. But this question doesn't speak about isolated relaxation of efferent arteriole. This question speaks about administration of a drug called AC inhibitor, and this AC inhibitor drug is going to inhibit angiotensin. Just because angiotensin is getting inhibited, there will be, to begin with, vasodilatation of efferent arteriole. More than that, there will be, next to that, there is going to be vasodilatation of afferent arteriole. But more than everything, look at this statement. How will the tubuloglomerular feedback mechanism respond to a primary increase in GFR? Now you are supposed to answer the second question here. How will tubuloglomerular feedback mechanism respond to primary increase in GFR resulting from vasodilatation? The question is clearly saying GFR is getting increased, which means you cannot counteract the question itself saying that GFR is getting decreased. No, the question is asking you that GFR is increasing and what mechanism will happen later. So you have to find an answer to support the question, not to fight with the question. Alright, so yes, alright, you guys are clear there. Kritika, non-compensated since bicarbonate almost normal. Kritika, bicarbonate is not almost normal. Bicarbonate is exactly normal, Kritika. Don't worry. Alright, bicarbonate is precisely normal. So everyone, yeah, thank you, Mohammed. Everyone got this answer right. Kritika, it is not because of almost normal, Kritika. It is exactly normal, ma. You got this, ma. Kritika, just let me know if you got it. If not, we'll move on to the last three questions. So yeah, guys, ECG tracing shows that PR interval progressively lengthens with each heartbeat until yeah, Roshan, GFR increased, more delivery. Exactly, more delivery. You're right, Roshan. Yes. 18, ECG tracing shows PR interval progressively lengthens with each beat until QRS complex is dropped completely. The cycle then repeats. The pattern is characteristic of. Okay, beautiful, beautiful, beautiful. Oh, fantastic, guys. Superb answer. It's going to be second degree AV block, Mobitz type 1, and that's going to be Venkiback. Precisely right answer. Good, good. So, good. I hope you guys are clear there. Fantastic. So, for your reference, I've given here first degree AV block. This is manifested by simple prolongation of PR interval. Simple prolongation of PR interval, that's going to be, first degree heart block. Second degree heart block, of course, you are going to find the classical presenting feature, both Mobitz type 1 as well as Mobitz type 2. The classical presenting feature is going to be missed beats. So there will be obviously a missed beats, which means there is going to be no QRS complex followed by P wave. So if you see no QRS complex followed by P wave, this is a classical finding associated with second degree heart block, guys. So in between two P wave, there is not going to be any QRS complex. It's a classical finding in second degree heart block. And third degree heart block, you guys were answering, I think SK's question, right? Third degree heart block is associated with Canon A waves. Most of you were answering well. So we're so happy. SK, that was a beautiful discussion you started. Divya, Kritika, you got it. MS, Sandhya, I always mark the ground. Why, Sandhya? Why you are missing this question? Sandhya, do let me know what is bothering you. Where is your doubt? Why are you getting confused with this choice? If you find a gradual increase, just be clear here. Sandhya, make sure you are clear here. Alright, you see that PR interval is small. PR interval is gradually lengthening, PR interval is even more lengthening, and then there is a missed beat. So if you see a gradual prolongation, it is going to be Mobitz type 1, also called as Venkiback. But if the beat is fixed, if the duration is precisely fixed, alright, so fixed PR, fixed PR. If the duration is fixed and there is a missed beat, it is Mobitz type 2. Alright, Sandhya, I hope you get this point, ma. Alright, fixer PR in type 3. MS, in type 3, you don't get a synchrony between P wave and QRS complex. There is no synchrony at all. There is a irregular pattern. P wave can happen on its own, QRS complex can happen on its own. You cannot find a steady relationship at all. Alright, so that's third degree MS. Alright, Harshimran, prolonged PR type 1 Mobitz, constant PR in type 2 Mobitz. Very good, Harshimran, you are right there. Alright, Amit Padri, you very good, guys. You are perfectly right. Sandhya, I hope this training will clarify your doubts and you would be improving from this point onwards. I believe so. I wish you all the best as well. Yeah. Riluzole, no, Riluzole. 6-sinus syndrome has got a different condition. Anyway, we'll come to that later. So question number 19. 40-year-old woman presents with central obesity, purple striae and hypertension. It's clear, alright? There is a central obesity, there is a purple striae, and there is also going to be hypertension. Now, you could have easily diagnosed this. This is a case of hypercortisolism. And the option says a low dose. The option says the subject is put on low dose dexamethasone suppression test. This fails to suppress cortisol. So what do? They go for very high dose dexamethasone suppression test. This is also fails to suppress cortisol. And very important point, when it comes to her ACTH level is found to be very low. So what is the point here? Even when the pituitary gland is not producing ACTH, there is going to be so much production of cortisol. So this cannot be happening from pituitary gland or hypothalamus. This must be happening from adrenal gland itself. So very clearly, this is a case of adrenal adenoma. Very good. Why not Cushing's disease? Because if it happens to be Cushing's disease, it will be manifested by increase in adrenocorticotrophic hormone, which is contradictory to the question. So option A is ruled out. Option B, ectopic ACTH producing tumor. If it is a ectopic ACTH producing tumor, this must be associated with increase in adrenocorticotrophic hormone as well. But the question says ACTH level is low, so option B is also ruled out. Coming to option D, iatrogenic Cushing syndrome. If it is iatrogenic, this is because of exogenous administration of steroid, which means there may be increase in dexamethasone, increase in betamethasone, whatever it is. So this will lead to increase in exogenous steroids. exogenous steroids, which means there will be a drop in endogenous cortisol. Cortisol is the hormone, it is not the drug, isn't it? So the level of cortisol will be less and the level of exogenous steroids will be more. That is the characteristic feature of iatrogenic Cushing syndrome. So you are ruling out everything, and the best answer is going to be option C, adrenal adenoma is the right answer, guys. People, I have given you the table for your reference. All right, what happens with low dose cortisol, what happens with high dose cortisol for your reference. So this will give you enough clarity, and the second table will tell you why it is not iatrogenic Cushing. So this is for your reference, guys. Anyway, I hope you guys understood what is right and what is wrong. Bhavdarani, low dose tests to confirm hypercortisolism. Perfect answer, Bhavdarani. Very good, ma. Low dose dexamethasone suppression test is to confirm whether there is hypercortisolism or not. Alright. Whereas high dose is to find the cause. Beautiful answer. Very good. Good. MS adrenal adenoma, mineralocorticoid B to increase hoga. Yes, MS. There is also going to be an increase in activity of mineralocorticoid receptor. Please remember, it is not increased mineralocorticoid. Alright. So please remember, if there is primary adrenal adenoma, this can be of two varieties. Please remember, MS, this can be of two varieties. If this adenoma comes from zona glomerulosa, you call this condition as Conn syndrome, which means only in Conn syndrome there will be mineralocorticoid excess. There is going to be too much of aldosterone. Alright. If the adenoma is arising from zona fasciculata, where the adenoma is going to produce cortisol, you are going to call this as Cushing syndrome. Alright. When it comes to Cushing syndrome, in Cushing syndrome you are not going to get excessive mineralocorticoid production. Rather, there will be excessive mineralocorticoid activity. Reason is, every time there is going to be increase in cortisol level, this increased cortisol level is going to act on both glucocorticoid as well as it is also going to activate mineralocorticoid receptors. Alright, they are going to activate both the receptors. So there may be an apparent mineralocorticoid activity, but that doesn't mean aldosterones are getting overactivated. Please remember, in Cushing syndrome, cortisol is going to take over the mineralocorticoid receptor as well. That's the reason. Alright, good. So I hope you are clear with this point, MS. Okay, perfect. SK, you are clear there. Low for screening, high for confirm. Very good. SK, Riluzole. Yeah, perfect. Harshimran, very good. SK, perfect, guys. Perfect. Right. Yeah, coming to question 20, people. A simple question. A patient with cardiogenic shock is given dobutamine, a beta-adrenergic receptor agonist. Activation of beta-1 receptor in cardiac myocyte leads to an increase in heart rate and contractility primarily through which of the following second mechanism? This is a beta-1 receptor, and this is going to acting through what second messenger receptor pathway? Yeah. Go ahead, people. Answer. Beautiful. It is going to activate GS protein, and that is going to lead to increase in cyclic AMP synthesis. Fantastic. Beautiful answer. Good. It's a one-liner question, guys. And this table will give you every single hormone acting in every single pathway. Alright. So I'm going to share the whole PDF to the people in the tech team, and those guys will be sharing this PDF in the app itself, people. So you'll be having every single question, every single answer, annotations, references, everything well. All right. So that completes today's discussion. People, have a pleasant good night, and let us meet each other in the next session possible. All right. So God bless you. Good luck and good night. If there is any doubts, please get it clarified. If not, you can leave, guys. I'll wait for a few minutes if there is any doubts. Thank you, Rizol. Thank you, Kirti. Thank you, Pa. Thank you, Tulsi. Thank you very much. Thank you, SK. Thank you, guys. Yeah. Can you please explain JVP waves? Yeah, sure. Beta 1 to 3 mechanism, please. Oh, thank you. All right, guys. I'll explain 1 and Gaurav doubts. JVP waves and beta 1 to 3 mechanism. Simple. Coming to beta receptor, beta 1, beta 2 as well as beta 3. All these three beta receptors will be basically G protein coupled receptors, and every time when it comes to adrenaline, or noradrenaline for that matter, adrenaline or NORET for that matter, what's going to happen is they will be activating this G protein coupled receptor. Usually when G protein coupled receptor gets activated, this G protein, which has got three subunits, alright, alpha subunit, beta subunit and gamma subunit. This G protein has got three subunits. In the presence of adrenaline and noradrenaline, what happens is this one subunit, doctor, alright, here it is. You are going to see this alpha subunit which is going to be moved away. You're going to find this alpha subunit which is going to be separated from beta and gamma subunit. This alpha subunit that goes and activates an enzyme, and that enzyme is going to be adenylyl cyclase. Once adenylyl cyclase gets activated, alright, very sorry. Once adenylyl cyclase gets activated, we'll put it this way. Adenylyl cyclase, as it gets activated, this in turn converts adenosine triphosphate. This converts adenosine triphosphate into cyclic adenosine monophosphate, and this cyclic adenosine monophosphate is going to exert its effect by in turn activating another second messenger called as protein kinase A. So that is the way with which beta 1, 2, 3 adrenergic receptors is going to get activated and exerts their function, doctors. Alright, so that's your question. Okay, good. Bavadarni, thank you so much. I am deeply humbled, and you practically made my day. So my sincerest thanks from the bottom of my heart. Thank you, Bavadarni. God bless you. Alright, and we have the next question. Of course, someone was asking about JVP. It's simple, pa. So when it comes to jugular venous pulse, let's put it this way. You have A wave, and A wave is because of atrial contraction. A wave is because of atrial contraction, and this is going to be called as X descent, and X descent is because of atrial relaxation. And then you have C wave, and C wave is because of isovolumetric contraction of right ventricle. Isovolumetric contraction of right ventricle. As a consequence, this is going to push the tricuspid valve to get bulged into right atrium. So there is going to be bulging of tricuspid valve into right atrium, and that is going to make the wave to get appearing, C wave. Alright, and coming to V wave, this is because of venous filling. So here it is going to be V wave, and V wave is because of venous filling of right atrium. Alright, and of course there is going to be Y descent, and Y descent is because of passive filling of ventricles. Now, doctor, if you have specific doubt on any of these waves, please do share. Or if you are not able to understand the whole JVP sequence, I recommend you to watch the JVP discussion we had in app, so that you will have the clarity. And then if there is any doubts, anyway, the number is always there, guys. Whatever point, you can ask me your doubts through Telegram or WhatsApp, not a problem. Fine. And Gokul, does renin increase GFR? Yes, Gokul. If there is going to be renin is going to produce angiotensin 2, and angiotensin 2 is going to constrict efferent arteriole primarily to begin with. Alright, so at that low level of renin, angiotensin 2, if efferent arteriole alone gets constricted, there will be increase in GFR. Right, so that's Gokul's doubt. And Harshman, Can you tell me important topics once for last revision? All right, Hashman, I'll do one thing. Please, let's discuss all these points in our Telegram group. All right, the Telegram group is called Physiology Trident. So all these doubts, important topics, and I'll share it in the group here, guys. Let's address the doubt alone here. All right, Hashman, fine. So okay, इसकी atrial cunt GQ and GS confusion होता है, beta में GQ होता है. Okay, that's okay, fine, that's perfect. See, when it comes to G protein, yes, Gaurav, it's simple, Gaurav. See, let us take up a G protein here, and when it comes to G protein, you know that it has got 3 subunits. The G protein is made of 3 subunits. It's going to be alpha subunit, it is going to be beta subunit, it is going to be gamma subunit. If at all, if these G protein gets activated, and because of activation, if this alpha subunit, you see here, if this alpha subunit goes and activates adenylyl cyclase, I'm going to name this as GS alpha, because S stands for stimulation. The alpha subunit is stimulating adenylyl cyclase, and hence this is called as S. If this alpha, in case, Gaurav, in case if this alpha happens to inhibit adenylyl cyclase, I'm just saying, if this happens to be inhibiting adenylyl cyclase, you're going to call this as GI alpha. In case if this alpha happens to inhibit the same enzyme adenylyl cyclase, this will be called as GI alpha, because I refers to inhibition. If the same alpha subunit goes and activates another enzyme called phospholipase C, and that leads to increased quantity of inositol triphosphate, increased quantity of diacyl glycerol, then this alpha subunit is going to be called as GQ alpha. So based on the activity done by the alpha subunit, the name is given as either GS or GI or GQ. All right, so that's Gaurav. V filling, passive filling of ventricle. Kritika, X descent can be considered due to ventricular ejection. Yeah, that's a beautiful word, Kritika. Point is, when it comes to the X descent, we can divide the X descent into 2 halves. All right, this is not for, of course, PG entrance level. To be clear, this is beyond that. Maybe in a super specialty level, we can say this way. All right, so X wave can be divided into 2 halves. Number 1, it is going to be the first half of X descent, and the second one is going to be the second half of X descent. All right, so let's put it this way. Sorry, there was a small technical glitch. Okay, so if you take up the X wave, of course we were talking about the first half and second half, right? The first half is because of atrial relaxation, and the second half is because of the ventricular ejection. All right, which is the X descent after C wave. Kritika, be clear. The X descent before C wave is because of atrial relaxation. The X descent after C wave is because of ventricular ejection. You got this, Kritika? So this X is atrial relaxation and this X is ventricular ejection. But for entrance exam, NEET, INI-CET as well as FMGE, you please be clear. This is the X descent and that's because of atrial relaxation for our level alone. All right. Yeah, perfect, Kritika. So I hope the session went well, guys. I hope this gave you enough clarity and idea. So in case if you have any further doubts and you need my support or help, of course, this is my Telegram channel. You can access me through Physiology Trident. If not, if you need explanations, this is my WhatsApp number as well, my business WhatsApp number. You can very well WhatsApp me in this number and you can get your doubts addressed, guys. So that completes the session. And yes, thank you, doctors. Thank you very much for your time and participation. Your doubts made me to stay enthusiastic. So thank you very much, people. Good night. Good night.